Welcome, everyone. Hello, good afternoon, good morning, whatever you are. Welcome to this month's Focus Bites webinar. Thank you for joining us today. My name is Daria, and I'm the Global Learning Program Manager with POCUS Certification Academy, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you may have throughout the webinar. Today's topic is how to differentiate various types of shock with POCUS, and our speaker is Dr. Mavani. Dr. Mavani has been a practicing cardiologist for 7 years and currently works at Geisinger Health System. He's board certified in cardiac CT, nuclear cardiology, echocardiography, and vascular ultrasound with RPVI to care for patients with all types of cardiac and vascular diseases. Dr. Mavani is currently working on a cardiac MRI board certification. Welcome, Dr. Mavani. We're so excited to see you today, and thank you so much for joining us.
Hello, everyone. I'm Dr. Mavani. I see that everybody is from all over the world, and thank you so much for joining us from different time line and different, maybe somewhere is night, somewhere is more early morning. That shows a lot of interest in this topic. And I'll try to do justice to this topic, and we'll do the question answers at the end of the presentation. So I'll start with my PowerPoint. So we'll talk about the role of point-of-care ultrasound in shock states. Most of you know the shock in our medical field is most people with a blood pressure less than 90 systolic and MAP of less than 65 millimeter per mercury. And that's one of the biggest critical patient we have in the ER and ICU. So objectives for the talk is differentiate various states of shock by using point-of-care ultrasound, and also figure out the shock physiology and mistakes to be avoided based on POCUS data. So various shock states would be cardiogenic, came first in my mind because I'm a cardiologist, but usually it is septic or hypovolemic. The third most common is obstructive shock, and then cardiogenic shock would be the last one. I don't think we should define those in this topic. We'll just go through the slides and figure out different shock states based on the POCUS ultrasound. So why we use point-of-care ultrasound nowadays than we did before? We used to have Swan, Gans catheters, central lines. All of them has invasiveness, plus it can cause a lot of complications. And this is easier way to differentiate most of the time and get the diagnosis very quickly. So it's very easily accessible technology. You can carry the small ultrasound probe in your pocket nowadays, and also use the Sonosite or other companies' ultrasound machine in ICU or even on the floors running the code. So knowledge and techniques are very important, because if you don't do the proper technique, you can misdiagnose many patients. The biggest advantage of POCUS is time to diagnosis is significantly reduced, because you have it at the bedside. You don't have to wait for a technician, or you don't have to wait for echocardiographer to come, which may take an hour or more. Usually we do the cardiac images, lung images, and subcostal images. For cardiac images, there are mostly the easiest images are subcostal views. And the second other, which I would suggest to do, is learn some parasternal views. And rarely you may get apical views, which would be very good if you can, but it's the hardest part of the shock states, because most patients are supine. And it's very hard to get them left lateral to get the apical images properly. So parasternal, usually we do it in second left or third left intercostal space around this area, with a pointer looking at the upside, and make it a vertical probe. And you can see the short axis images, which I'll show you And subcostal, you go to subxiphoid with the same thing. Your pointer is up and looking towards the lever to get the IVC. So these are the parasternal short images. I put two of them because there is a difference in those two. The first one is you can see that it's a short axis at a mid-cavity level. The way you know it, there is a papillary muscle here and a papillary muscle here. That tells you that it's a short axis at mid-cavity. This is where you can, usually 90% of the time, you can figure out the myocardial activity, or I would say ejection fraction. Then if you do this one, which is almost towards the mitral valve, many times you miss many things with the base of the heart because it can be hypercontractile in many states, including stress-induced cardiomyopathy, non-ischemic cardiomyopathy. You may have wall motion at the apex or mid-wall, or you can have even septic shock causing some of these hypercontractile base of the heart. So if you are doing the parasternal, always look at the mid-cavity level by changing the probe, move up and down the probe or sideways. This would be the parasternal when your probe is more horizontal. This, you may get some of these images. It's not hard and fast that you should get it, but if you have short axis, you have more idea. This is mainly the aortic valve and the mitral valve, but this doesn't help as much as the short axis images. And then the subcostal images is the main for most of the shock states, which helps us a lot. One of them is IVC, or inferior vena cava. Second thing is pericardial fluid. You may see the site is RV function and sometimes LV function if you get a good images in the subcostal area. And I think if you practice on more patients, you may get better at short axis from subcostal. So based on IVC data, there are many different papers came out in cardiology field, especially to see what would IVC suggest, imaging of IVC suggest. So main thing is the size and collapsibility helps determine the right atrial pressure. And the normal RA pressure is 0 to 5, but mostly 0 to 3 millimeter per mercury. And when you have more than that, it means there is an increase right atrial pressure, which means more right ventricular filling pressure went up as well. Now, normal IVC size is less than 2.1 centimeter, less than or equal to 2.1. Now, there are patients which they have the normal IVC size more than 2.1, and that's very rare. I would say that usually people who are very young in their 20s, they may have normal IVC of 2.2 centimeters. But then you have second portion, which is the collapsibility with sniff test or respiration. Now in the shock states, sniffing is very hard to do. So mostly you will just see by the inspiration collapsibility. So if the IVC is less than 2.1 centimeter and collapses more than 50% of the time, it's normal RA pressure. If IVC is more than 2.1 and collapses less than 50%, is 15. And in between those two, it's very hard to remember, but if you remember 1 and 2, you can figure out the third number, which is IVC is normal, but doesn't collapse as good as you would like to collapse less than, it is usually less than 50. And that number is 8. We used to have different numbers before, and everybody thought it was 5, 10, 15, but somehow more data came out and it shows 3, 8, and 15 is more accurate with right heart cath numbers. The IVC more than 2.1, but does have collapse of more than 50%, is usually 8. And that's for most patients, not for younger people who can have 3 millimeter mercury with the same IVC size and more collapse. And these are some examples, and this image shows your right atrium here, and then interatrial septum, left atrium here. This is your IVC, and this is your hepatic vein. So this is your lever area. This whole thing is a lever. And then if you see that IVC does collapse, and these small points are 1 centimeter. So it's less than 2.1 and it's collapsing more than 50%. So that right atrial pressure is normal in here. And this is the sniff test because this patient was awake. I just wanted to get the normal IVC first. Now, this is the example of IVC, which is kind of, if you see this 2, it's 2.1, and it does collapse almost 50%. And this one is a similar, just a color flow here. There is IVC is normal, but it's not collapsing. So this one has a big IVC, collapses normally. This one is a normal IVC, but does not collapse at all. So both of these are 8. Both of these means high right atrial pressure. Now, this is, most of the people will know this one because you see the IVC is right 2.1 and doesn't do any movement with respiration. And you see the hepatic vein here. Same thing in this IVC. There is no collapse. So this is 15. So there are some exceptions. One is a patient on a ventilator usually has a dilated with less collapse and would be around 8 millimeter per mercury. So most patients, when you see the IVC when they're on a ventilator, if you see is normal size and not collapsing, or bigger size but collapsing, it may be normal for that patient and their volume status is okay. There is not too low or too high. However, if the IVC is small, very small and collapsing, that means patient has hypovolemia. That means patient on a ventilator should have a bigger IVC with less collapse and still has a small IVC. Second exception is severe tricuspid regurgitation can have big IVC and may collapse normally. Now that's very rare, and you may see the right heart very big before severe TR happens. The third one is a COPD or pulmonary chronic can have dilated IVC as well as more than 50%, mostly more than 50% collapsibility. And then one other thing is if IVC is more than 3 centimeter with no collapse or less than 50% collapse, it may be very high right atrial pressure, 20 to 25. And this helps normally when you have full echo to check the PA pressure or RV systolic pressure. For POCUS and diagnosing the shock, if you know those two, like normal, which is less than 3, and abnormal more than 8, then you will be okay. Now, lung images, it was a little tough for me to understand the whole idea of lung images, but I did talk to the pulmonologist in our system who does a lot of lung images nowadays than used to before. This can help us with different volume status as well. The A lines, B lines, pneumothorax, pneumonia, pleural effusion. These are the things you can diagnose on lung images. So normally when you put between the two rib cage, when you put the cursor, this will be the pleural line. This is your cursor here. This is your fat tissue. That's your pleural line, and it will have the A line exactly almost same distance as this one. And those are normal A lines in the lung ultrasound. There are some topics of sliding of the pleural line, which would help us in more complex patients. Now, the B line is mainly you have a pleural line, and all this reverberation area of vertical lines are B lines. And these B lines suggest that there is a fluid in that area. Now, this can be multiple different things. One is pulmonary edema, second is ARDS. We'll talk about that. Now, this is very rarely you can see this one, but this shows air bronchograms here. And there is no vertical lines or horizontal lines. There is no A or B. It's just a whole area of different variety of echo density. So this can be pneumonia. And this is the one which is showing the two sign. One is a seashore sign in this area, and the stratosphere sign in this area, which is like this, horizontal lines. And those are mainly, this is classic for pneumothorax. So pleural line, and then you have the stratosphere sign. Now, we do use false protocol in critical care unit mostly, and that came out to rapidly rule out obstructive shock first, and then cardiogenic, and then hypovolemic, and leads to diagnosis of distributive shock. And most of them are septic shock. It bases on lung ultrasound with A profile, which is normal, and B, which is pulmonary edema. So the first one is obstructive shock. If you have a big right ventricle, there may be a PE. At the same time, cardiogenic shock if you have a low EF, which is very hard to diagnose. And then hypovolemic shock will be the one with IVC view. But in this false protocol, what they would do is when they don't have A or B, they have A line but no B line, they give the fluid bolus. And if the patient improves hemodynamically, but do not have B line developed, then you have hypovolemic shock. If there is a B profile, then the authors cited that most of them are septic shock. However, from cardiac standpoint, I see some of the pitfalls. One of them is it does not take too much into consideration of IVC. If you see that small IVC with B profile usually means ARDS or non-cardiogenic pulmonary edema, while small IVC with A profile likely hypovolemia. So both of them have small IVC. They are B or A profile, is none of them are septic shock. Now you can have small IVC with A profile and low EF, which would suggest mixed picture, because low EF does not always mean cardiogenic shock. People can have low EF and they can still come with a septic shock or hypovolemic shock. And in that case, you do have a lot of importance to IVC. Sometimes you can have an elevated JVT also, but if you have IVC is pretty small, you can give fluid. Overall, in our situation, in our practice, what we say is if you can give fluids, and you can give fluids in most of the patient if IVC is small, and diurese them later. The reason for that is lack of volume creates cascade of processes, which becomes harder to reverse as time goes by. So if you miss septic shock, if you miss hypovolemic shock, just by looking at short axis images, and you see that the EF is low, then you are already behind the game, and you may just lose patients' hemodynamics. Eventually, none of the pressor support or inotropic support would help because there is no volume to vasocompress them. And then now I have a few questions for the listeners, see if we can get some of those questions and do the polls and then go from there. And we can do the question answers about the whole topic. Based on these three questions, we'll ignite some of the more questions you guys will have.
All right, let's see. First question should be on your screen. Feel free to answer the question. Right. I see the responses coming in, so we'll give a minute to everyone to read and respond. Okay, I see about 40% responded to the question, so feel free to answer the poll.
And we won't be checking who are wrong and who are right, so don't worry about that. Just answer, then we'll go into detail about why it is wrong or right.
Thank you. All right, I'll give another 10 seconds, so we'll wrap it up here. All right, and here's the results. Let me know if you can see it, Dr. Mavani.
Yeah, so this is very good. 71% were right. All of them can be done. Echocardiogram can be done, but it will take, at least in my place, it takes about an hour or more. Especially at night, we have to call the echo tech in, or you may have to get the machine down and do the full echo. And that's really a tough job in the situation of shock. Consult cardiology, well, you can always do that, and they can come and do the POCUS. Critical care would be involved once you have diagnosis. So if this patient comes to ER, the ER doctor or whoever is taking care of them, family medicine, any of the providers, physician assistants, extenders, if you do the ultrasound POCUS, you can get most of this out of the way, and then you can focus on what is the main diagnosis. So I would do the POCUS first.
Great, thank you. Let's go back to the second question. Okay, first person answered. All right, here we go. Okay, we have about 20% people who participated in the poll, so I'll give another 45 seconds.
I think this is a little bit harder than first.
A little harder. So we can give you extra time. Right. Another 15 seconds and we'll go into the results. Okay. And here's the results.
Wow, this is good.
Very close.
Almost equally divided into things. So acute CHF could be there, but if you see, I think the main two lines in the question is X-ray is clear and patient has a lower extremity edema and there is no murmur or lungs are clear on examination. Heart rate is 110, respiration is high, 20. Saturation is low, 88%. So this patient has some sort of heart failure. No, I should have said acute left ventricular heart failure because that's what normally we go by. Pulmonary embolism, D-dimer is normal. So most of the time you rule out is very high negative predictive value of a D-dimer. So pulmonary embolism, less likely in this patient. Pneumonia could be because small mild leukocytosis is there. X-ray is clear though, and then pro-BNP is borderline. IVC is normal, no pericardial fluid. So pneumonia would be showing at least some on the X-ray. I understand that you may have clear X-ray initially. When you hydrate them, you may see the pneumonia. Now, why would I choose last one, COPD? Because if you see the lungs are clear, legs are swollen, and JVD is high, so they have acute and chronic core pulmonal. Most of the severe COPD patients comes with lot of leg swelling, and they have core pulmonal. So if you try to do other things such as acute PE, you start happening other things, I would go towards COPD and treat that COPD exacerbation, give some fluid, because when you have core pulmonal, your right heart is already not doing well. So fluid always helps. Even though there is edema, when you have shock, you can give fluid with the right heart failure. Once their pressure is up, once their COPD is better, then you can slowly diurese them. So the answer would be last one, COPD.
We do have one question in regards to this case. How did the GAVP elevated to jaw but IVC is normal? What conditions can cause these discrepancies?
So IVC could be JVD is high because SVC is normally in COPD. If you do the SVC ultrasound, you may see dilated SVC all the time with the JVD. But IVC could make you figure out if there is a volume hypovolemia. So COPD can have severely dehydrated patient, and IVC would be small. At the same time, the way they're exercising muscle use and the lung issues, they may have JVD all the time with SVC dilatation. In that, you can do an ultrasound of the SVC. If you can get the SVC, you will figure, you can easily do that ultrasound to figure out if it is COPD or cardiac tamponade, but that's a detailed view of SVC.
Okay, thank you so much. Should we go into the next question? Two people responded, so I can zoom the question. Dr. Mavani, would you like to read the question for the audience?
So a 53-year-old female with history of hypertension, diabetes, smoker, comes to emergency room with sudden collapse at a grocery store. So they call 911, EMS reach, and blood pressure is 70/0. Heart rate is 90, actually 90 beats per minute. Respiratory rate is 12. Saturation is 96% on room air. They did the EKG, which shows normal sinus rhythm with diffuse STT changes, no ST elevation. After 1 liter of fluid, blood pressure comes up, respiration goes up, and the saturation is 92%. Patient is awake but lethargic, no focal deficit. Lung exam reveals crackles at bases. Cardiac exam reveals regular rate and rhythm, no murmurs, no S3 or S4, no edema. CBC CMP comes normal in ER. Rest of the labs are pending. POCUS shows IVC of 2.2 centimeter with normal collapsibility with inspiration. No effusion of pericardium or ascites. Subcausal views shows likely reduced LV systolic function. What would be your diagnosis?
Okay, this may be a hard one, but we got 64 people participated out of 152, so about 45%. So we'll give another 45 seconds for you guys to digest and respond. All right, and here are the results.
So majority is correct. It's a cardiogenic shock. The main reason for not being septic shock is you have EKG changes. Once you give fluid, your respiration goes up, your saturation goes down. You have a low EF on subcostal views. IVC is big, and when you have those classic high-risk people for CAD, hypertension, diabetes, smoker, 53-year-old female, you likely have a cardiogenic shock. Like I would say with subcostal low EF by POCUS, mostly have a low EF by full echo. Septic shock is probably not the answer. Pulmonary embolism usually have, once you give fluid, they would get better with blood pressure. Their heart rate gets better. However, their IVC would be normal. And also they won't get the crackles because they're already, it's mainly the right ventricular obstructive shock. COPD will be unlikely because this patient has no other signs of COPD that we know from this. Mainly I focused on EKG findings with fluid. The right answer was the fluid first, but then you see that the lungs sounds pulmonary edema. Then you have a POCUS showing dilated IVC. Then you have low EF. So cardiogenic shock would be the right answer. Now this is a catch in here because when you have 70/0 blood pressure, when you give 1 liter bolus, your pressure gets better. Most of us are afraid, but as soon as you see the low EF, people are afraid of giving fluid. And that's when the problem happens because people can have cardiogenic shock and still be hypovolemic initially. The main idea is to get the pressure up so that they don't get the anoxic brain injury, they don't get the circulatory arrest, they don't get the secondary hypoperfusion with renal failure and liver failure, all those things. Once you hit the blood pressure, once your patient is a little stable, you can always figure out how to treat the cardiogenic shock.
Okay, thank you so much. And I think these are all the questions for the quizzes, but we can move towards our Q&A portion of the presentation. So feel free to submit it in the Q&A box. Our first question is, regarding IVC readings, are they applicable to pediatrics?
No, actually it's not, because most of the pediatrics patient, it may help in a small IVC, then you know it's hypovolemia. If it is a normal size or a big IVC, it could be normal for that child.
Thank you. Next question is, actually, I see some questions about case number 3, so we may have to go back. In patient with cardiogenic shock with reduced EF, 1 BP be affected by IV fluids as we push PT further to the right of the Rank-Starling curve?
So initially it would go up. If you give 2, after that, once you reach to the point of plateau, and then you start declining your blood pressure, because then what happens is you start having hypoxia from pulmonary edema, and then that will affect your cardiogenic shock, because then you have more oxygen demand, less supply, and your myocardium is going to be more at threat.
We have another question. What is CMP on this question?
Complete metabolic panel, so liver function, kidney function, electrolytes.
Great. Thank you. Okay, going back to the Q&A portion. So next question is, do you normally use phase array or linear probe for lung images?
We use phase array.
Next question is, how do you assess the pressure the IVC easily?
Pressure of the right atrium. The question is to check the pressure of the right atrium, or let me see the question.
I'm not sure. This was submitted by anonymous attendee, so if you want to type a little bit more information for this question.
How do you assess the pressure line, the IVC easily?
We'll move maybe to the next question. So if someone wants to specify. Question from Carlos. I have been using the mitral valve EPSS as a way to grossly identify LV function. Should we use short axis parasternal view as more accurate to determine LV function in shock state?
So EPSS is a good way of knowing if EF is low in parasternal long axis. However, EPSS can be falsely normal in the patient with stress-induced cardiomyopathy, because your base portion and up to mid portion would be normal or hypercontractile versus apex are completely not seen, and you will miss the low EF. With short axis mid cavity view, you usually don't miss that.
Thank you. I have one more question. Which POCUS device are you using at your institution?
So we have two. One is in our cath lab, which is a Sonosite, and then one we have in our ICU is mainly the Butterfly.
In the low resource setting, is it ever possible to use curved array, or is it too dangerous?
I don't think it's dangerous. You can still use it.
Any tips do you have on obtaining a beautiful IVC views like the ones in your presentation?
I think most of the time, I would say 90% of our patient have a good IVC view. The main thing is to really press, and sometimes you press too much and you lose the IVC. So you have to really start with the superficial view and look at the lever, and then slowly press deep down. But keep looking at the ribs. Don't look down too much, because then you will start looking at the stomach or intestine. Once you can start with view of our right ventricle, right atrium, and then change your view and your probe towards the lever to figure out where you are exactly in the anatomy. If you start straight to IVC, you may not get it. So start with apical subcostal, and then you move towards the IVC.
We also have a couple of infographics on our website, so if you would like to check those out for the best tips and tricks, I would highly suggest that as well. Next question is, can you please explain why parasternal short is preferred over parasternal long view, and why mid-papillary view is preferred?
The reason for it is mainly if you do the long axis parasternal, you usually see anteroseptum and the basal infralateral wall mainly, and then up to the mid infralateral wall. And those two are the main area which is usually hypercontractile in septic shock, also in stress-induced cardiomyopathy, or with mid to distal LAD disease, where you don't see those regional wall motion. And mid cavity, usually you end up seeing all 6 walls, and it's very hard to miscalculate the LV function. You won't be getting the full EF, but at least you will know it's very low or normal. And how do you measure the ejection fraction? We usually use ejection fraction as a biplane method. And that is mainly the apical 4-chamber and also 3-chamber, and that's full echo. I don't think you can measure the EF by POCUS.
Okay. Next one is, sometimes in PT with chronic right heart failure, severe HFpEF, they have permanently dilated and non-collapsible IVC despite being I'm sorry, I have to learn some of these words.
Volemic or hypovolemic,
Yes.
and it keeps on assessing fluid status in this situation, this condition. So chronic right heart failure, severe HFpEF, usually have dilated IVC and despite hypovolemia. Those are very rare, and usually you can't use the POCUS for those complex patients. They will always have big IVC, big no collapsibility, and hypovolemia would be the main way to do it is by looking at, in this situation, I would use right heart cath. And then what would you measure on echo? TEPC enough? I don't think TEPC is enough for many reasons. One is TEPC can be normal in pulmonary embolism because right ventricle is mainly a longitudinal wave, and then you can have a base and the apex very hypercontractile and a free wall is very weak. And that's a McConnell sign to diagnose pulmonary embolism. Most of the time, if you don't suspect B dimer is normal, you can use the IV, the TAPC. And there is another one which you can use is S prime. It's the same as E prime on the lateral mitral annulus. You can use the same similar one on the right side annulus to see how is your S prime, and that would give you the normal is more than 10 centimeters. Because sometimes you don't get the good good TAPC if you're not longitudinal or not the best view to do the TAPC, you may get it lower.
I think we just had one more question come in. If you don't have B lines in a lung ultrasound, can you rule out pulmonary edema?
If you don't have B line on the lung ultrasound, can you rule out? I don't think so, because the main thing is B lines are helpful when you see it, but doesn't mean that there is no pulmonary edema. Because mainly the lung ultrasound, we do it at the mid zone of the lungs, at the almost mid chest level, axilla and the back of the chest or the scapula. And those areas can have no pulmonary edema, but if you go down to the bases, you may have some crackles. So I would suggest to do the physical examination. And if you feel that B line is not there and patient still has pulmonary edema, then I would go with the pulmonary edema with a dilated IVC.
Okay, last call for any additional questions that you want to submit to Dr. Mavani. One more came in. What is your opinion on using M mode to measure IVC diameter?
That's a good idea. I mean, you can use the M mode. Most of the time, we should use M mode. Now, M mode, if you use it, once you start using the regular ultrasound, then you get good at it and you know those dots. But M mode is the best way to do it. You can see the collapsibility and all those things very easily.
Great, thank you so much. We have a couple of more minutes, so feel free to submit any questions that you may have. If you don't have any questions, we just launched the poll, and if you can take some time to answer our question, if you learned today anything, and leave us any feedback so we can plan our future webinars for you. But I just wanted to thank Dr. Mavani for this great presentation, and thank everyone who joined us today from all over the world. Thank you so much, and we hope to see you at our next webinar. All of these webinars are being recorded and will be posted on our website, and you will receive a link next week. And you can rewatch this presentation, and if you have any more questions for Dr. Mavani, just let us know. We'll be more than happy to connect you. Thank you so much, Dr. Mavani. It's been a pleasure.
Yeah, there was one question about how to easily do the IVC pressures. I would suggest to do only two things. One is normal, and one is more than 15. In between, is 8. So if IVC is normal, collapses normally is normal filling pressure of right side, and it's less than 3 millimeter per mercury. If it's dilated, not collapsing, it's more than 15. In between, if you miss something, if you say it's 8 or 10 or 6, nobody's going to say that you are wrong, because the mainly is more than 15 and less than 3, which matters more.
Thank you.
Thank you, everyone. And some of you will have a night, so have a good sleep, and some will be waking up. So use this POCUS for helping you in the decision making.
Definitely. Thank you so much, Dr. Mavani. It's been a pleasure having you, and we hope to see you in the future in our webinars. Thank you.
Yep. Bye-bye.